أعزائي طلبة المرحلة الخامسة، السلام عليكم. In the previous lectures regarding genitourinary tract diseases, we discussed one of the important and common problem, and that was the urinary tract infection. And we have said that for urinary tract infection there are predisposing factors, there are etiological factors, and we talked about the clinical manifestations or the clinical features of this common disease. Also, we discussed the laboratory investigation and imaging tests that are related to the diagnosis of this common disease. And before we start the treatment of such disease, we should be sure about the diagnosis. And definitive diagnosis of urinary tract disease depends on combination of the typical clinical features and the findings in urine. And on urine examination, we should search for two important factors: the presence of the neutrophil and the presence of nitrite. These two can usually be detected in symptomatic infection by urine dipstick test for leukocyte esterase and nitrite respectively. The absence of these two, I mean the nitrites and the leukocyte esterase in the urine, makes the possibility of urinary tract infection to be unlikely. So you should detect these two factors in urine analysis or urine examination before we say with sure that this patient has urinary tract infection. Also, any urine taken by suprapubic puncture normally should be sterile. There should be no organism in urine aspirated from suprapubic or through suprapubic puncture. So the presence of any organism here in this specimen of urine is considered to be significant. Added to that, if the patient has symptoms and there are neutrophil in the urine, a small number of organisms is significant. Also, sometimes the patient may have no signs or symptoms of urinary tract infection, but there is significant bacteriuria, and this is called asymptomatic bacteriuria. Whenever we have more than 100,000 organisms per ml as detected in urine, in urine. Now, after we get sure that this patient has urinary tract infection, the next step is how to treat. Antibiotics are recommended in all cases of proven urinary tract infection. This is the first point. Basically or ideally, the antibiotic is chosen according to the results of culture and sensitivity. But treatment may be started while waiting the results sometime. Sometimes we are obliged to start the treatment before we get the result of urine culture and sensitivity. After we get the result of this test or lab test, we may change our mind. We may choose the appropriate antibiotic according to the culture and sensitivity test. We have many antibiotics or antibacterials that can be used in the treatment of urinary tract infection. We have the trimethoprim, we have nitrofurantoin, quinolones, antibiotics such as ciprofloxacin and norfloxacin, and we have cephalexin. All these are effective in the treatment of urinary tract infection. And it is important here to highlight a point that among pregnant ladies or pregnant women with urinary tract infection, there should be avoidance of some of these antibiotics. Trimethoprim, sulfa derivatives, tetracyclines, quinolones, all are to be avoided in treatment of urinary tract infection during pregnancy. And this table shows you many antibiotics that can be used effectively in urinary tract infection with their doses and duration of treatment. An entity of urinary tract infection among all people or all patients. Here there are some parameters to be taken into consideration. They might not be applied to urinary tract infection among young adults. First of all, among elderly, the prevalence of symptomatic bacteriuria rises with age. It rises to 40% in women and 30% in men. The other point that is related to the urinary tract infection in old age or old people is that there are contributory factors for urinary tract infection among this age group. And these include an increased prevalence of underlying structural abnormalities, postmenopausal estrogen deficiency, and an increased residual urine in women as a contributory factor for urinary tract infection. And with an increasing age, we have the prostatic hypertrophy with decreased or reduced bactericidal activity of prostatic secretion among old men. Another point which is considered in the such disease among old people or old patients is decision to treat. Would you treat a patient, elderly patient, with asymptomatic bacteriuria? It was found that there is little evidence from treating asymptomatic bacteriuria in old age. First of all, it doesn't improve chronic incontinence. If the patient, elderly patient, is suffering from chronic incontinence but still with asymptomatic bacteriuria, it was found that there is no extra benefit from treating these patients by antibiotics. Also, it doesn't decrease the mortality or morbidity from symptomatic urinary tract infection. The other point is that when we prescribe antibiotic for every elderly patient or old patient with asymptomatic bacteriuria, we may enhance or encourage the appearance of bacterial resistance. The other point which is related to the urinary tract infection in old age group is that urinary tract infection or urinary tract is the most frequent source of bacteremia in older patients admitted to the hospital. Also, another point which seems to be unique for urinary tract infection among elderly patients, and that is incontinence. A new or increased incontinence is a common presentation of UTI in older women. Such symptom is not encountered usually among urinary tract infection among young adult women or young adult men. Another important entity that we used to face related to the urinary tract is recurrent urinary tract infection. And recurrent urinary tract infection is common whenever there is repeated infection by the same organism after treatment, or if there is reinfection with another organism after an interval. And once you are faced with such patient with repeated urinary tract infection, then we should think about an underlying cause for that, and the patient should be investigated thoroughly, or a detailed investigation is justified in these patients. Because urinary tract infection, particularly in the presence of underlying cause, may result in permanent renal damage, whereas uncomplicated infections rarely do so. So it is very important to investigate a patient with recurrent urinary tract infection in order to find any underlying cause. And sometimes we may find an underlying cause, but there is no way to remove. So if an underlying cause cannot be removed, suppressive antibiotic therapy can be used to prevent the recurrence at least, and to reduce the risk of septicemia and renal damage. Because recurrent urinary tract infection among patients with underlying structural abnormality is a factor for permanent renal, or a risk factor for damage of the kidneys, and it is a risk factor for septicemia among these patients. One of the common entities that we used to face is asymptomatic bacteriuria, and from its definition you may have a lot of bacteria in urine but with no symptoms of urinary tract infection. Such asymptomatic bacteriuria is getting more and more with age. It is common in those aged over 65. There is no evidence that this condition causes renal scarring in adults who are not pregnant and who have normal urinary tract, and in general treatment is not recommended or indicated. So if we don't have underlying structural abnormality in the urinary tract, and just we have asymptomatic bacteriuria, it means that there is no need for treatment. But it is not every patient with asymptomatic bacteriuria, he or she doesn't need treatment. Sometimes treatment for this entity of urinary tract infection is justified, and the treatment for asymptomatic bacteriuria is indicated in the following situation. First of all, whenever we are dealing with an infant with bacteriuria or asymptomatic bacteriuria, whenever we are dealing with a pregnant woman with asymptomatic bacteriuria, and whenever we have urinary tract abnormalities. In these three situations, we must start antibiotic therapy for a patient with asymptomatic bacteriuria. Now we reach another very common entity that we use, or you used to face in the hospitals. We have many patients in the hospital with enduring catheter or with urinary bladder catheterization. And the entity that we use to see among these patients is the catheter-related bacteriuria. In patients with urethral catheter, bacteriuria increases the risk of gram-negative bacteremia 5-fold. So those patients with indwelling catheter or with permanent catheterization or frequent catheterization, they have more chance to have bacteremia than those without urinary bladder catheterization. Bacteriuria is common among these patients and almost universal during long-term catheterization. Treatment for this patient is usually avoided in asymptomatic patients, as this may promote antibiotic resistance, as we have said in the previous lectures. And according to the golden rule in medicine, which says that prevention is rather than cure, careful sterile insertion is important, and the catheter should be removed as soon as it is not required. If you want to avoid such entity, which is the catheter-related bacteria, which is with its potential risk or hazards, we should use aseptic technique during insertion of this catheter, and we should not leave the catheter for a long time. It should be removed as soon as it is not required. The other entity of urinary tract infection, which is a severe form of urinary tract infection, is the acute pyelonephritis. It is acute renal infection. Presents as a classic triad. We have three important clinical features that are related for this disease, and these are low in pain, fever, and tenderness over the kidneys or the renal angle. Regarding the etiology of this acute pyelonephritis, it is almost always caused by organism ascending from the bladder, and bacterial profile is the same as for lower urinary tract infection. It means that the same bacteria that causes the lower urinary tract infection, once it gets up or once it ascends up, it will cause acute pyelonephritis. And for this disease to happen or to take place, there are what is called predisposing factors. And the predisposing factors for acute pyelonephritis are whenever you have structural kidney disease like cyst or renal scarring, whenever the patient is diabetic, and whenever we have chronic urinary tract obstruction. Sometimes with analgesic nephropathy you may get this entity of urinary tract infection. Those with sickle disease are more prone to develop acute pyelonephritis than others. And sometimes acute pyelonephritis is associated with papillary necrosis. Another entity of this pyelonephritis, what is called a necrotizing form of pyelonephritis, with gas formation between two brachys emphysematous pyelonephritis. This is occasionally seen in patients with diabetes mellitus. Another sort of what seems to be a chronic entity of pyelonephritis is called xanthogranulomatous pyelonephritis. It is associated with obstruction and characterized by accumulation of funny macrophages, and generally the treatment for this entity of pyelonephritis is nephrectomy. And for the diagnosis of acute pyelonephritis, we should consider other possibilities. The manifestation of acute pyelonephritis may simulate other clinical entities. So the differential diagnosis of acute pyelonephritis includes the following. Acute appendicitis may present in the same way as acute pyelonephritis on the right side. Diverticulitis may give the same manifestation of acute pyelonephritis. Cholecystitis, acute cholecystitis, may give clinical features which are similar to that of acute pyelonephritis on the right side. Salpingitis among women, ruptured ovarian cyst, and ectopic pregnancy among women, also all these may give clinical features or signs and symptoms which are similar to pyelonephritis. So all these possibilities should be considered before we decide this patient has acute pyelonephritis. Sometimes we have an entity which is the perinephric abscess. There is marked pain, tenderness, and bulging in the vein on the affected side. In this situation, although the patients are extremely ill, but urinary symptoms are absent, in the sense that the patient may have no dysuria, no hesitancy, no frequency, and the urine contains neither pus nor organism. So this is the differences between perinephric abscess and acute pyelonephritis. Now, how to manage a case of acute pyelonephritis? Infection of the cyst in polycystic kidney disease require prolonged antibiotic. This is the first fact to be considered. It is not the same as for urinary tract infection, simple urinary tract infection. And sometimes rehydration is required in severe cases. If complicated infection is suspected or response to the treatment is not marked or promote. Urine should be cultured and renal tract ultrasound performed to exclude urinary tract obstruction or a perinephric collection. And whenever there is obstruction, drainage may be by percutaneous nephrostomy. Sometimes you have a pyelonephritis and there is obstruction, and sometimes the only way is to drain the kidney to the outside by a nephrostomy tube. Thank you very much.